Today, we're tackling a procedure every medical professional knows, but, well, maybe few truly master,
Right.
the digital rectal exam, or DRE. And if you think the DRE is just a basic, maybe slightly awkward step on a clinical checklist,
Hmm.
the consultant-level surgical sources we've gathered are, I think, about to fundamentally change your mind. This is a high-stakes tool.
It absolutely is. Our mission for this deep dive is to move far beyond the superficial how-to. We want to reveal the hidden anatomical map that a clinician is navigating.
It's a great way to put it.
We want to show you the essential why, the vital layers, the precise surgical landmarks, and the critical correlations you need for, high-stakes diagnostic.
Across multiple specialties, too.
Exactly. When a physician performs a DRE, they are using their finger as an extension of their anatomical understanding.
Okay, let's unpack that versatility first.
Yeah.
Because the core takeaway from these protocols is that the DRE isn't just about the colon or the rectum. It's an anatomical crossroads.
That's the perfect way to phrase it. We define it as a systematic digital assessment of the anal canal, the rectum, and those crucial surrounding pelvic structures.
Right, the surrounding structure.
And because of that strategic location, deep in the pelvis, it gives us indispensable insights into colorectal health, for sure, but also urological health,
The prostate, of course.
especially the prostate gynecological conditions, and maybe most surprisingly, neurological function, bowel control, tone, all of it.
So let's begin where the process begins.
Yeah.
The indications. I went through the laundry list of reasons we do this test and sort of grouped them to make them more memorable.
Oh, that's a sharp approach.
I see 3 primary goals here.
Okay, what are they? And I wonder if they're all equally weighted in clinical practice.
That's a good point. The 3 buckets are, first, symptom investigation. This is the most common entry point, right?
Absolutely.
Bleeding per rectum, painful defecation, chronic constipation, or that feeling of tenesmus.
That distressing, constant feeling of incomplete emptying.
Yeah. Second is structural screening. This is the life-saving part. Looking for suspected carcinoma of the rectum, or critically in males, evaluating the prostate. And third, maybe the most complex, is functional and preoperative assessment. So evaluating neurological bowel dysfunction or assessing pelvic floor tone, that kind of thing.
Structurally, you're right. Symptom investigation is the most frequent trigger, but the value of the DRE, I think, often lies in the other two.
Right.
Now, before any of that, the sources stress the preparation steps. They're non-negotiable, but they often get rushed.
Things like consent and privacy.
Exactly. Explaining what's going to happen, getting explicit consent, ensuring absolute privacy. Those steps are vital for the patient's comfort, and they improve the reliability of the findings because the patient is more relaxed.
And what about positioning? It's not just about lying on your side, is it?
Not at all. The standard, the default, is the left lateral or Sims position.
Lying on the left side with knees drawn up.
Right, but, and this is important, if you suspect a lesion that is high up or mostly posterior, so towards the sacrum, the position changes.
And which position is best for that kind of deep posterior access?
That would be the knee-elbow position.
Sounds awkward.
It might sound awkward, but gravity actually helps the patient's abdominal contents fall forward a bit. This relaxes the pressure in the pelvis and allows for deeper, more targeted access to that posterior rectal wall.
So that small detail changes the success rate.
Entirely. And don't forget the standing bent forward position, which is favored in some prostate clinics because it allows the prostate to descend slightly and making it more accessible.
This brings us to what the sources flag as a huge Viva point. The one non-negotiable step that, well, many new clinicians rush through.
I know exactly what you're going to say.
The biggest mistake flagged is skipping the visual inspection. You have to look first.
It is absolutely non-negotiable. The eyes gather evidence, the finger just cannot. You're looking for signs of chronic conditions, specifically a sentinel pile.
Which is that classic skin tag.
A skin tag indicating a chronic, maybe healed anal fissure. You look for fistulous openings, which can be tiny holes, signs of prolapse, skin issues, and critically, the presence of soiling.
Which immediately suggests what?
Potential incontinence or neurological dysfunction. Skipping that inspection is like missing the first half of the exam.
Okay, so now that we know why we go there and the preliminary steps, let's get into the core of it, the map you're navigating. This is where it gets really interesting.
Absolutely. Let's quickly review the technique. It's really 2 main parts.
Yeah.
Part A focuses on the anal canal. The gentle insertion is designed to assess 2 things. The resting anal tone, which is the involuntary internal sphincter,
Right.
and then the voluntary squeeze, which is the external sphincter.
And part B, the rectum itself. What's the technique for this 12 to 15 centimeter structure, it's not just a simple poke, is it?
Oh, no, it's a systematic sweep.
Yeah.
The examiner has to sweep their finger circumferentially, a full 360-degree assessment.
You're really mapping the whole surface.
You're mapping the quality of the mucosal surface, feeling for masses, ulceration, any sign of stricture and narrowing. You check anterior, lateral, and posterior walls meticulously.
And the final step.
Always remember the final diagnostic check, inspecting the glove when you withdraw. You're looking for blood, mucus, pus, or just the character of the feces.
Now for the landmarks. The surgical sources highlight 4 critical anatomical boundaries. Let's start at the entrance.
The entrance is the anal verge, the skin junction. It's simple, but it's important. This is where hair-bearing skin meets the anal canal, and it's the typical spot for external hemorrhoids.
But the real aha moment, surgically speaking, is the dentate line, the pectinate line.
Yes. This line, which is only about 2 centimeters above the verge, dictates. Well, it dictates everything.
It's an invisible line, but it's that important.
It's the line that dictates diagnostic urgency and surgical staging. It marks the junction of the embryonic ectoderm and endoderm, and because of this, everything changes. Nerve supply, blood supply, lymphatic drainage.
Wait, hold on. Let's slow down on that. That's a huge surgical implication. So you're saying a carcinoma that's 1 centimeter below that line versus 1 centimeter above it is treated completely differently.
Completely differently. Below the dentate line, the tissue is highly pain-sensitive. The nerve supply is somatic, like your skin. A tear here is intensely painful.
A fissure.
Exactly. But above the line, the tissue is pain-insensitive. The nerve supply is visceral. That's why internal hemorrhoids, which originate above this line, often don't cause pain.
Not unless they prolapse or something.
Precisely. So a patient could have significant bleeding from a high-grade internal hemorrhoid and feel no direct pain, but a tiny superficial fissure lower down is excruciating.
That's incredible. And that leads to the drainage difference, right?
It leads directly to it. If you have a malignancy below the dentate line, the lymphatic drainage follows the skin pathway to the inguinal nodes.
The nodes you can feel in the groin.
The ones you can easily palpate. But if the pathology is above the line, the drainage is internal. It follows the superior rectal vessels all the way up to the inferior mesenteric nodes.
So it's a completely different, much higher stakes oncological pathway.
A completely different world.
Wow. That just proves why this is so much more than a quick check.
Okay.
Landmark number 3, the one that gives the canal its structural integrity. The anorectal ring.
You feel it as this firm, circular, really robust band.
And why is it so rigid?
It's rigid because it's not one muscle. It's a confluence of 3 crucial, powerful structures all working together. It's formed by the puborectalis muscle, the internal sphincter, and the deep part of the external sphincter.
The puborectalis is the one that loops around and creates that critical angle, isn't it?
That's the one. And the fact that this is a combined, firm band makes the anorectal ring an incredibly important landmark for staging low rectal tumors.
How so?
If a tumor breaches that ring, the implications for sphincter-saving surgery are drastically changed. It often means a much more aggressive surgical approach is needed.
You're basically mapping out the structural defenses of the whole pelvic floor.
That's a perfect way to think about it.
So if we firm out, the anal canal is only about 4 centimeters total, reflecting that division. Then you have the longer rectum, 12 to 15 centimeters, starting way up at the S3 vertebra.
And the rectum itself is complex. It's defined by its curvatures. You have the big anteroposterior or sacral curvature that follows the tailbone. And then you have the lateral curvatures, the valves of Houston. These are 3 crescent-shaped folds on the inside that can sometimes be mistaken for a mass if you don't know the normal anatomy.
That's a great clinical warning. Okay, let's connect this map to what you can actually feel. Segment 3, what can you feel? And the critical context here, you said, is the peritoneum.
This is absolutely vital. The peritoneal relations of the rectum change based on height. The upper third is covered anteriorly and laterally by peritoneum.
Right.
The middle third is only covered anteriorly, but the lower third has no peritoneal covering at all.
Why does that matter to the clinician during the exam?
It directly informs risk. If I'm probing high into that upper third, I'm near the rectovesical pouch in males or the rectoureurin pouch in females.
Which are both covered by peritoneum.
Right. Pushing too aggressively there carries a risk of irritating or even penetrating the peritoneal cavity, which drastically raises the stakes. Conversely, if you're looking for a fistula lowdown, you know you're in a retroperitoneal space.
And because of that, you can feel structures that seem totally removed from the GI system.
We're talking a true multi-system assessment here. If you palpate the anterior wall in males, you are feeling the prostate, its size, consistency, tenderness. You can also assess the seminal vesicles.
And in females.
In females, you're assessing the cervix and often the lower part of the uterus.
So a DRE is fundamentally incomplete if you only think about the colon.
Precisely. Posteriorly, you always feel the sturdy resistance of the sacrum and cossicles, and laterally, you're assessing the ischiorectal fossae.
Those are the fat-filled spaces on either side.
Yes, the spaces that allow the anal canal to expand. Tenderness or a boggy swelling in those lateral areas immediately suggests an abscess.
Okay, let's translate touch into diagnosis. We're assessing the prostate, the rectal wall, pelvic floor tone, feces. Let's connect specific findings to diagnoses.
All right, if you feel a hard, irregular mass that's fixed to the underlying structures, that is a major red flag for carcinoma of the rectum. A hard, shelf-like consistency.
Okay. What about something inflammatory?
A tender, boggy swelling that feels soft, warm, painful, that points right to an abscess, probably in that ischiorectal fossa.
And what if it's just intensely painful to even start the exam?
If the patient is guarding and the whole canal feels tight and painful on gentle insertion, that is the classic severe sign of an acute fissure.
And on the functional side, what if you find a significant loss of tone during that voluntary squeeze test?
That immediately points to a potential neurological injury, something impacting the external sphincter control, which is the pudendal nerve. It's a critical finding, especially in trauma patients.
And the glove, what you see on the glove.
The color of the blood can offer clues. Bright red is often lower down hemorrhoids, a fissure. But maroon or dark blood suggests a more proximal bleed, like from a malignancy or colitis.
To bring this all to a close, let's just hammer home those critical consultant-level Viva points. The final takeaways.
First, never underestimate its power. The DRE can detect up to 70% of rectal cancers. It's a mandatory screening tool.
70%, wow.
Second, always remember, if the patient has severe pain on insertion, you must assume it's an acute fissure until proven otherwise. It's the most common and painful localized condition.
And the third point.
A point specifically for male patients. Never skip the prostate examination during the DRE. It's part of the comprehensive assessment. Failing to do it is a clinical error.
This has been a true deep dive. We started with what seems like a basic medical concept and uncovered a complete surgical map. The dentate line, the anorectal ring. It's a comprehensive multi-specialty assessment.
Indeed. It proves that mastery in medicine is always about connecting the small physical finding to the large underlying anatomical structure. And to leave you with one final thought, let's return to the ischiorectal fossa.
The large fat-filled space lining the sides of the anal canal.
Yes. This space is bounded laterally by the gluteus maximus muscle and the obturator internus. Its fundamental function is purely mechanical.
What does it do?
It allows the anal canal to expand and move during defecation. It's a space designed for mobility, and yet it's the most common site for deep, painful abscesses that dramatically restrict movement.
So the body has this dedicated fat-filled cushion to ensure the canal can function, but when that cushion gets inflamed, the entire system just seizes up.
Precisely. Consider how tightly the basic movement of defecation relies on the mobility provided by that space, bounded by those massive pelvic muscles. If that space becomes rigid or inflamed, the action of muscles like the gluteus maximus becomes immediately tied to anorectal health.
It shows just how interdependent the anatomy of the pelvis really is.
It does. And why a clinician's ability to sense firmness or bogginess in that lateral space is so vital. Think about that interplay of mobility and rigidity the next time you consider the function of the pelvic floor.